Well, thanks everybody for joining us. I'm really excited about today's session. I'm going to do the didactic, and then we have two good complicated cases to discuss that have to do with pneumocystis and KS. But for the first segment, I'm going to turn to tolerability of the integrase inhibitors and a little bit more about neuropsychiatric and other side effects from dolutegravir. First thing I'd like everyone to do is get ready for some polling questions, actually. I'm really curious what you all think about a couple of things that has to do with how we select our first line or initial regimen for a treatment-naive patient. So if you could all please pull up your ResponseWare app or rwpoll.com and get ready for a couple polling questions. I'm raising this topic because it's been on my mind, and it's been on my mind for two reasons. One, now that we have so many different first-line regimens and a lot of them are integrase, I've really been thinking lately about how we choose between them and some of the pros and cons, and so I'm curious to ask your opinions about that. And then number two, there's just been a lot at conferences and published lately about dolutegravir and neuropsychiatric side effects and conflicting data. Is dolutegravir better tolerated than other first-line regimens? Is it worse tolerated than other first-line regimens? So I'd like to ask you about your experience on a couple things. I'll show you some data, and then we'll have a conversation. And with that, again, please get ready for some polling questions. If you're just logging on, ResponseWare app or rwpoll.com, and wait for it. Away we go. Okay, poll is open. Here's what I'd like to ask you. Which of these regimens do you prescribe, or if you're not a prescriber, no problem, please weigh in. Which would you recommend most frequently for a treatment-naive person who's starting medications right away? So which one of these do you find with your patients or clients you're recommending most commonly? So I've given you dolutegravir plus a tenofovir combination, TAF-FTC or TDF-FTC. I've given you dolutegravir with abacavir 3TC, so this would be Triumeq. I've given you elvitegravir-Cobi TAF-FTC, which is Genvoya, or elvitegravir-Cobi TDF-FTC, which is Stribild. Raltegravir plus a tenofovir combination. Boosted darunavir plus a tenofovir combination, and then also the rilpivirine combo tabs, Complera and Odefsey. Although these technically are on the alternative list, I think for a patient with viral load less than 100,000 and CD4 count above 200, they often are considered for initial therapy. So I'd really like just to hear, there's no right answer here. With your patients or clients, which one are you recommending most frequently? Kent, why don't we broadcast that? Okay. Thanks everybody for weighing in. So it looks like we're fairly evenly split between A, B, and C. So I think that a lot of our community is veering towards dolutegravir and sort of split between tenofovir or abacavir as first choice. So that's very interesting. We'll come back and look at some data and talk about that at the end, and maybe talk about some pros and cons of either one. Again, there's no right answer here. And then a little over a third opting for Stribild or Genvoya. Perfect. Thanks, everybody. So another polling question. Let's open this one. In your experience, again, whether you're a prescriber or not a prescriber, which of these integrase inhibitor regimens do you think is the best tolerated? Again, no right answer. Dolutegravir with a tenofovir product, dolutegravir with abacavir lamivudine, Stribild or Genvoya, the elvitegravir-based combos, raltegravir with a tenofovir combo, or in your experience, they all have pretty equal tolerability. Curious what you think. Again, no right answer here. So this question is, which one has the best tolerability? Kent, let's show that. Okay. A little more of a spread here. So I think the majority answer for best tolerability for raltegravir, about 30% saying all have pretty equal tolerability, and then a spread between the other answers. Okay, thanks everybody for weighing in. Last polling question here. I'm very curious about that. In your experience, what percentage of your patients or clients have stopped dolutegravir in any combination because of intolerability, because of side effects? I've given you some options here: 0%, 5 to 10%, 10 to 20, 20 to 30, or greater than 30. I'm very interested to see the results here. And then what I'll do after this is I'll turn to some data that looks at tolerability of integrase inhibitors and side effects of dolutegravir. And then I'd like to have a little longer discussion about this after the slides. Kent, let's show that. Okay, so 5 to 10%. A few maybe a fifth of participants saying 0%, 80% saying 5 to 10%. No one going up higher than that. Okay, fantastic. Thank you so much, everybody, for weighing in. Just as a reminder, these are the first-line regimens for initial ART by the DHHS guidelines. I think you all know this quite well. These are the integrase inhibitor-based regimens and the one boosted PI-based regimen still on the list for first line. Although if we look at the IAS USA guidelines, they really say we should be looking for an integrase inhibitor combined with TAF, whether it's dolutegravir, elvitegravir, or raltegravir. And I guess I should say combined with TAF or abacavir. They really veer away from TDF and away from the boosted PIs. So the IAS USA guidelines are a little stricter in their list. Now, back in 2014, there was a systematic review that assessed the odds of discontinuing dolutegravir compared to other standard regimens. And I bring this up because it caught my eye. So what you see here is the odds ratio of discontinuation of dolutegravir compared to other frequently used regimens. And what you can see here is that the odds of discontinuing dolutegravir, they found to be less than any of these other regimens, with the bold ones being statistically significant, the non-bold ones being not statistically significant. So their conclusion was that dolutegravir is the best tolerated and least discontinued ARV. This caught my eye because A, that hasn't necessarily been my experience. B, the systematic review was, half the authors are employed by the drug company that makes dolutegravir, which raises my eyebrow. And 3, most of their data, most of the studies included were for efavirenz and had much less data for the other regimens. So I found this systematic review to be suspect, and I wanted to look at what's been published after 2014 and what we know since this time related to tolerability of dolutegravir and integrase inhibitors. So this one we've talked about before, but I'll start with this one. So this was just published in AIDS. This is a review from the Netherlands that specifically looked at dolutegravir. So they reviewed 556 patients who were treatment naive or experienced but starting dolutegravir anew, and followed over time. About 15% discontinued dolutegravir, most of those because of side effects or intolerance, for a final 13.7% who discontinued dolutegravir because they didn't tolerate it. Now, when this came out, I raised it here on Echo. It caused some stir because I think this was certainly higher than in clinical trials and higher than most of us have experienced in clinic. And if I go by our poll we just did, it sounds like most in our community are seeing maybe 5 to 10% of people discontinue dolutegravir due to side effects. So this is a bit higher than that. The most frequent reason in the study was insomnia or sleep disturbance. And the other interesting thing that came out of it is that not tolerating dolutegravir was more likely if dolutegravir were combined with abacavir as compared to if dolutegravir were combined with TDF. That will come up a couple times here, and so one thing I'm curious to ask you is at the end is if that's been your experience. Is dolutegravir harder for a person to tolerate if it's combined with abacavir? Let's look at a couple of other studies that we haven't talked about here on Echo. So this is a retrospective review from Germany. It's a larger study. It's about 1,700 individuals who started any of the integrase inhibitors in 2 different clinics between 2007 and 2016. And I've just summarized their data for the individuals who discontinued that integrase inhibitor by 12 months, either due to any adverse event or due to a neuropsychiatric adverse event. And I think there's a couple interesting things here. So one, if we look at dolutegravir, elvitegravir, and raltegravir overall discontinued due to adverse events, we see that raltegravir is likely the best tolerated, consistent with what's been everybody's experience per our poll. Dolutegravir and elvitegravir, very similar discontinuation rates for intolerability, with the difference being most of the discontinuations for dolutegravir were because of neuropsychiatric side effects, whereas very few from elvitegravir were for that reason. I presume most of these were GI side effects from the COBE, but they didn't go into that. So it seems to me from this that dolutegravir and elvitegravir are discontinued because of intolerability, a similar rate simply for different reasons. With dolutegravir, it's more likely headache, insomnia, sleep disturbance, restlessness, worsening depression, a whole list of neuropsychiatric side effects. And with elvitegravir, it's more likely other side effects. But this again would be consistent with all of our experience, maybe 5 to 10% of people discontinuing dolutegravir. Interestingly, they also found that the neuropsychiatric intolerability with dolutegravir was more frequent in women, and you can see the hazard ratio here, which is not trivial, in older individuals, which they defined as above 60 years old, and again in those taking abacavir as compared to those taking tenofovir. One thing I will say is this has not necessarily been my experience. I agree with this rate of people discontinuing dolutegravir, but is discontinuation more likely in women and in older individuals? I was trying to think about my clinic and the folks who have not tolerated dolutegravir, and I feel like it's been more mixed. But I'm curious to ask you at the end what your experience has been. And then now we'll look at 2 studies from Spain. This, again, was individuals starting any of the integrase inhibitors. In this study, nearly all were starting an integrase inhibitor for the purpose of switch or simplification of their regimen. They had just over 2,000 individuals, and there's a little more data here. So I've given you dolutegravir with either of the NRTI combos, then dolutegravir with abacavir or with TDF, raltegravir again with either combo or with abacavir or TDF, and then the elvitegravir TDF-FTC combo or Stribild. And you can see here the overall who discontinued due to intolerability. In this study, actually discontinuing for side effects was more common with raltegravir, which surprised me. This was a poster at CROI, and they didn't say the reasons, the specific side effects, so I can't speak to that anymore. But overall, I'd say if you look at this column, it's pretty similar in terms of the rate of people who stopped due to side effects. What's maybe not surprising is if you look at this column, the rate of discontinuation due to neuropsychiatric side effects, again, is most common with dolutegravir, driven by those who get dolutegravir combined with abacavir, with the caveat that they had a much lower number of those getting dolutegravir with TDF. But again, this suggests dolutegravir is more likely to have neuropsychiatric side effects than the other integrase inhibitors, and maybe when combined with abacavir, that's more likely. Again, this study found a higher risk of dolutegravir discontinuation due to side effects in women. In this study, this was for any side effect. They did not find the same association for neuropsychiatric side effects. They did not find an association for age. This other study from Spain, again, looked at individuals starting an integrase inhibitor, looked at the number who discontinued within a year due to adverse event or neuropsychiatric adverse event. Again, here you can see pretty equivalent, pretty comparable between the integrase inhibitors. Neuropsychiatric side effects more common with dolutegravir, but overall not that common, but certainly more likely than with the other agents. But once again, you're noticing a pattern. Discontinuation with dolutegravir was twice as likely if it was combined with abacavir as compared to if it was combined with other NRTIs like TDF-FTC. So there certainly is a pattern here. This study found more discontinuations with older age, but the hazard ratio was just above 1, not nearly as impressive, and I couldn't quite figure out how they defined older age either. So finally, an abstract from CROI that didn't look at rates of discontinuations, just looked at the rates of reported neuropsychiatric side effects and found about 25% with dolutegravir. But what they did was they looked at dolutegravir neuropsychiatric side effects and compared it to dolutegravir plasma levels. And the punchline was that higher plasma trough concentrations of dolutegravir led to higher neuropsychiatric side effects. I don't think we know what to do with that yet, but it does suggest that maybe plasma levels and toxicity is related to BMI, or maybe, like with the favrins, maybe some people are genetic slow metabolizers versus fast metabolizers, and maybe there's some sort of genetic predisposition to higher dolutegravir levels and more neuropsychiatric side effects. But just to summarize, this is my summary of those studies that have been published since that systematic review. That first one we talked about from the Netherlands that found a pretty strikingly high rate of dolutegravir discontinuation, mostly because of neuropsychiatric toxicity and a higher risk with abacavir. And then these 4 studies that looked at all the integrase inhibitors, I've just given you a mean rate of discontinuation here at the bottom, with dolutegravir overall being slightly higher, but that includes this sort of outlier, this study from the Netherlands. Actually, if we strike that outlier, it becomes 4.8%, and the rate of discontinuations, I would say, is equivalent between the 3, between dolutegravir, elvitegravir, and raltegravir. So my summary of this data really is that the likelihood of intolerability is low, maybe 5% or so, and similar between the 3 integrase inhibitors, and maybe it's just the risk of side effects, the type of side effects that's different. But that is a different finding than that systematic review in 2014. I should say, though, this was my informal review. This was not an official systematic review of any sort. This was just me wondering which drug is most tolerable. I'd also like to bring us back quickly before I wrap up and ask you your opinion to the TheStriving Study. So this was the study that enrolled individuals taking standard 3-drug ART and randomized them to either stay on that regimen or switch to abacavir, lamivudine, dolutegravir. And one thing that came out of that study was those who switched to that regimen did have more side effects. However, they also reported higher treatment satisfaction. So, in conclusion, I think the overall rate of discontinuation due to intolerability is fairly similar between dolutegravir and elvitegravir. In my experience in clinic, is raltegravir is a little better tolerated too, just like you all said. It's just limited because it's twice a day, and so we don't prescribe it as much. So we're prescribing these more. So I think these have similar rates of side effects. It's just a matter of risk of neuropsychiatric side effects from dolutegravir or risk of GI side effects from the elvitegravir Kobe is sort of the way I think about it. One important thing that did come out of these studies is that most of the side effects were grade 1 to 2. They were mild. A lot of them were actually present before the person switched to an integrase inhibitor. So maybe a person's history, maybe if they've had insomnia, headaches, depression, maybe if they've had those sort of symptoms before, maybe they're at higher risk. And importantly, most of the side effects resolved with discontinuation of the integrase inhibitor. It does seem like the risk of neuropsychiatric intolerability is higher with dolutegravir than the other integrase inhibitors. I'm not sure what to do with all this data that maybe the risk is higher in older individuals, maybe it's higher in women. Certainly, it seems consistent that the risk is higher if dolutegravir is combined with abacavir. However, abacavir, lamivudine, dolutegravir, or Triomec has the advantage of being 1 pill a day. So maybe there's slightly higher risk of intolerability with Triomec compared to dolutegravir with a tenofovir combo. But there's also the convenience of the 1 pill a day with Triomec. Abacavir certainly has advantages of not having risk to the kidneys and bones. So I kind of think it's a pro-con toss-up between those two. And I'd be really curious what you think. So with that, I'll end with these questions for you. And I'd love to hear your opinion. And we'll take a few minutes for questions and comments before going to cases. So I'd like to know from you, what do you think about this? How are you deciding between the different integrase inhibitors for starting someone? How are you counseling a patient about possible side effects, for example? Will any of this data I just showed you affect how you recommend these meds or counsel people about these meds? And then I'm curious about this too. Once daily raltegravir, 2 600 milligram tabs once a day is approved by the FDA, which it likely will be, how will that change your recommendations? And then this is more of a open-ended question without an answer. Once bictegravir TAF FTC is approved, will that be a significant improvement? Or what would make you lean towards that instead of the other options? But I'll stop talking there and open it up for questions, comments. I'd love to hear from you what you think about the differences between these first-line options. Anyone willing to dive in there with a question, with a comment, with your experience?